Welcome, everyone, this evening to our session. It's hosted by the National Network of Healthcare Hygienists, and my name is Colette Murray. We've got an amazing speaker tonight for you guys, Tamara Thomas. We currently have 5 certificates available on our educational platform. Most recently launched earlier this year is our Orofacial Recovery Certificate Program. And on that note, since several of you coming tonight are not dental hygienists, I thought I'd highlight this certificate program because it is available to any licensed healthcare provider. Tamara is a registered dental hygienist and certified specialist in orofacial myology with a passion for improving oral and systemic health. As the owner of Facial Physique Orofacial Myofunctional Therapy, she provides specialized care aimed at enhancing breathing and craniofacial development for both children and adults. Additionally, Tamara is an instructor for the accredited Oral Systemic Educator Certificate Program, which is our robust foundational certificate at the network, and she emphasizes the vital connection between oral health and overall wellness.
I'm excited to speak with everybody, and I'm pretty passionate about elevating our field and being able to spot these airway clues. I feel every hygienist should be able to see them pretty quickly, whether or not you're a myofunctional therapist as well, or trained in myofunctional therapy, or that patient to the right provider, I should say. And I did start doing myofunctional therapy or studying it in 2016. So in 2017 is when I opened my own practice called Facial Physique here in San Diego. And it really was just a side thing that I started, really to help children and adults, and for me too, because I had all the problems. And it became bigger than I had expected. So I realized that there is a huge need for all of us to be aware of all of this. So why are hygienists on the front line of airway health? First, we see patients more frequently than any other healthcare provider, making us the first to observe early airway or breathing changes. We are also trained in early detection and prevention, so we can observe subtle signs like mouth breathing, scalloped tongues, narrow palates, which can indicate airway dysfunction long before medical symptoms appear. We are highly trained in the connection between oral and systemic health, as we all know. So by learning how airway compromise contributes to inflammation, fatigue, sleep issues, and oral conditions such as bruxism, gingival inflammation, malocclusion, make us the first to bring these issues to the patient's attention. And surprisingly, I didn't know this probably till the last few years, but we have a professional responsibility. In 2018, the ADA released a policy encouraging dental professionals to screen for sleep-related breathing disorders and collaborate with medical teams for diagnosis and management. So that's a huge thing as far as bridging the gap between medical and dental. This is a way we can start to elevate ourselves as dental hygienists. Lastly, it gives us collaborative care opportunities. Our screening strengthened communication with area-focused dentists, ENTs, and sleep physicians, expanding our role as a hygienist into whole body wellness. And then most of all, our patients feel very cared for. I no longer am in clinical dental hygiene. I may temp here or there, but I do myofunctional therapy full time. And when I was in dental hygiene in clinical setting, I had a lot of patients thank me because I was able to get them help that they need. They didn't realize they were brushing, flossing, and doing all the things, but yet things were getting worse. And so looking into all the airway signs and getting them to the right medical providers really changed their life. So what is airway health? It's such a broad term. Even when I first started learning about it, I'm like, oh gosh, like that's crazy. And then of course, when you Google it, it'll talk about airplanes. So one of the papers that I was able to find, there was a definition on airway health, which is the state in which the upper airway, comprising the nasal passages, oral cavity, pharynx, and related musculature, remains anatomically open and functionally unobstructed during rest, sleep, and wake, allowing efficient nasal breathing, optimal tongue posture, and uninhibited craniofacial growth. Dysfunction in this system predisposes patients to mouth breathing, altered tongue posture, palate size, malocclusion, sleep-disordered breathing, and associated systemic impacts. So let's jump into the 5 key observations that we had talked about or presented earlier is what we were going to talk about. So there's lip seal at rest. We're going to evaluate that. Tongue rest posture and mobility, dental arch form, tonsil size, and patient symptoms. So let's start with lip seal at rest. You can really see easy signs of this in just everyday walking around, but mostly in the waiting room. So patients who are either filling out their medical history, watching TV, or reading a book, you want to, when you call them back, look and see, are their lips sealed and together? Are they cracked or are they open? Are they nasal breathing? That's one of the easiest things to start to observe. The reason why we want to observe that when they're doing something else is because that's what they most present with throughout the day. So other things to observe in addition to no lip seal at rest is mentalis strain. So mentalis strain is when the chin muscle dimples and it tightens to help try to close that upper lip. This usually is indicative of a lower jaw setting too far back. It doesn't have to be severe retrognathia, but it can still be a tiny bit to where those lips can't seal very easily. And then when they try to close the lips, usually it creates that mentalis strain. That being said, some providers believe that mentalis strain is not a tone orbicularis oris, which does contribute, but one of the underlying things that we should also be looking at is craniofacial growth. Another observation that we should be looking at is dry chapped lips from chronic mouth breathing and lack of natural moisture seal. This is definitely something that's chronic. So, I mean, here in San Diego, we get Santa Ana's, so it gets dry, and it's not everybody has chapped lips at that point, but we're looking at more of chronic chapped lips, not just seasonal. We should also observe anterior tooth exposure at rest. So if the front teeth are visible because lips don't fully cover the teeth, then we can say that's open mouth posture. I think that's the hardest one to kind of spot. In a picture here, I'll show you the difference. But if there's not complete seal, that is still considered open mouth posture. Lastly, we can observe an upper everted lip. That is when the upper lip is turned outward or rolled away from the teeth rather than resting naturally against them. So here are a few examples. Can you see my cursor okay? Hopefully you can. If not, let me know. The first picture, we can see that there's chapped lips, there's open mouth posture, and there's anterior teeth exposure at rest. The second photo, this is that mentalis strain that I was talking about with the lip closure. This isn't a comfortable position for this person. It definitely is open mouth because it takes so much strength from that mentalis to be able to close those lips. The third photo, we can see open mouth posture. We can see crowded teeth. It's not very clear, but he does have chapped lips, low tongue resting position, and that everted lip. So the lip is very tight and the philtrum is shorter. This last photo is the one that I was talking about that's really tricky to see or kind of right off the bat see. Also, it's tricky because so many people have lip fillers nowadays. So it's really tricky to see that there's a tiny bit of teeth exposure there. That could be a problem with mouth breathing. So we want them completely sealed together. Why does it matter? So if the lips are not sealed, then mouth breathing is more likely to occur. So when there's mouth breathing, there's likelihood of dry oral tissues, which decreases salivary production, contributing to increased risk of cavities by lowering the pH balance. We all kind of know this, but I'm just reviewing a little bit here. Saliva acts to neutralize acid in the mouth and helps to flush away bacteria. Without saliva, its benefits protective mechanism, risk of decay, and periodontal disease increases. And then the lowered pH balance can lead to erosion of tooth surfaces and increased sensitivity of the teeth to temperatures. So some mouth breathers who have sensitive teeth and you're not sure why, it can be from that mouth breathing and creating lower pH balance. Mouth breathing affects craniofacial growth because with mouth breathing, the tongue is low and forward instead of gently suctioned to the roof of the mouth, acting as our natural palatal expander. So my question is, how many of you have seen patients in a prophy who have clean teeth, very little buildup, if any tartar or plaque, and they still have very puffy anterior gums, and you're trying to figure out why? A lot of times, those are our mouth breathers. And so I know we've all seen it. I remember knowing all of this information, I would be so frustrated. And I'm sure I frustrated the patients too, because I'd be like, are you lying? Are you really flossing? I'm not sure, there's bleeding. So now I feel bad knowing what I know now. So let's go on to the next one, tongue posture and mobility. Note, I'm not going super in depth about mobility because really us myofunctional therapists are trained to do multiple things to assess that. I'm going off just things that you can quickly hone in on in a quick examination to be able to spot these things. So what to observe? For the tongue, we want to look for scalloped edges. Scalloped edges suggest that the tongue is pressed against the teeth and that there's most likely a low tongue posture and insufficient palatal width. So scalloped edges we know is where the teeth are kind of imprinted on the sides. Sometimes it'll be on the lateral borders of the tongue. Sometimes it'll be on the anterior. Sometimes it's the whole tongue. That is one of those red flags. We also want to observe if there's a heart-shaped tip or a notched tongue tip. This may indicate that there's a restricted mobility affecting swallowing, speech, and craniofacial growth. And then we also want to look at where the lingual frenum attaches. I'm giving a basic one of at the alveolar ridge or at the tip of the tongue because that's easy for us to spot. We were taught at least the tip of the tongue in dental hygiene, but as you start to learn more about mobility and function, a lot of things are missed by the dentists. So with the alveolar ridge, lingual frenum attaching to the alveolar ridge, it will create like an Eiffel Tower appearance. And I'm going to show you some photos here in a second of what that kind of looks like. Lastly, we're going to look at the floor of the mouth elevation when the tongue is lifted. I believe this is the one that hygienists can spot the most, because how many of us clean those lower anterior teeth and we're using our mirror? We have to push down that tissue that just keeps riding up. That is the floor of the mouth. And that is actually a compensation for limited tongue mobility. So here are some examples that sometimes you can spot it, like I obviously can spot it, but if you're not really have a trained eye, the one that would be the most apparent would be this one. This is the one that most dentists and hygienists and probably medical providers are like, oh yeah, it's pulling the whole tip of the tongue down. But all of these have limited range of motion, and we have to look at that a little bit more. So obviously this one is limited range of motion because of the tip of the tongue. We also want to look at the heart-shaped tip. So you can see this heart-shaped tip is pretty heart-shaped. This one's a little less heart-shaped, but if you can see, I'm not sure if you guys can see, but there's a tiny little notch at the end of that tongue, slight little heart-shaped tip. That's the variety that you can see in having limited range of motion. This one here and this one, you can see that it fans out and it goes on the alveolar ridge. That will contribute to limited range of motion as well. And then in this here, this is floor of the mouth elevation. So some of them are really severe, like I talked about, us trying to put our mirrors on the lower anterior lingual to clean those really well. Sometimes it's not quite that apparent, but all this tissue is being lifted with this tongue. If we were to hold that floor of the mouth down, this range of motion would be significantly decreased. Then I wanted to give a example of low tongue posture. This is me. This is why I'm in this field. Looking back at all my photos, this was my smile. This was my resting posture. I was class 3, of course, severe oral restriction, maxillary lip and tongue. And you can see that my tongue is forward and under. It's forward out of the mouth almost, in front of the teeth. The tip of the tongue should elevate to the incisive papilla. The middle should contact the middle part of the palate, and then same with the posterior part of the tongue. So why do we care about posture and mobility? Main thing is it contributes to poor craniofacial growth. It increases the chance of needing braces. Think of yourself and family members, but all the patients who need braces. And there's a whole rabbit hole I could go down on craniofacial growth with that. But in a nutshell, it increases the chance of needing braces. It also increases the risk of sleep disordered breathing, and restricted mobility may affect swallowing and speech. So if a patient has restricted mobility, a lot of them will be in speech for a long time and not be able to resolve. A lot of times we want to look at the mobility of the tongue. Can also contribute to TMJD. So let's go through the third observation, which is the dental arch. We'll go over a few clinical signs of poor craniofacial development and then red flags for airway concerns. So what to observe? You want to look at a high arch form. So the roof of the mouth is very high and narrow. That can be sometimes, if you don't have a trained eye for it, it's a little tricky. Some of them are very apparent. Some of them you're like, oh, that doesn't look so bad, but it still has, it's still problematic. Crossbite, most providers will say they will grow out of it, but this is a sign of muscle imbalance and an airway concern. Unfortunately, those kiddos don't grow out of a crossbite. They become adults with malocclusion and sleep disordered breathing. They're more likely to have that. We also want to look if there's crowding in the baby teeth or permanent teeth. That means there's not enough room in the arches, in the dental arches, to house all of those teeth. If there's recession that's there and it's not from, brushing too hard, that can be from grinding your teeth at night and not having enough of an alveolar bone on the buccal. Very common. If there's those shark teeth, so those permanent teeth growing behind the baby teeth, that is a very clear sign that the mandible or the maxilla is not to the size it should be to house the teeth correctly. Also bicuspid extractions to make room. So this is more for adults. There are orthodontists, sadly, that still do this, but it's less common. Tooth extraction and closure of that space. So if there's tooth extraction and an implant is placed, there's still maintenance of that arch. But if they're taken out and then closed, that will decrease the tongue space. And with a decrease in tongue space, it impacts correct tongue posture, which will lead to sleep issues. So here's examples of high arch and occlusal wear. I mean, we all kind of know occlusal wear, but the high arches. So this is a high arch, very, very, very narrow. This is also a high arch, but there's also some more information that we can see here. There's no room for this canine tooth to erupt. You can see 8 and 9 are very crowded. So, and then of course that high arch palate. And I can't see the chat, but I have a quiz question, not a quiz, just a question. This photo here, this is actually a thumb sucker. So thumb sucking pushes the palate up and becomes very narrow. And then of course that sucking mechanism will also make the palatal arch narrow. But what thumb do you think this child is sucking? You can put it in the chat. And then on this one, a lot of providers will see the grinding in those baby teeth, where you can see that incisal wear. That is a huge red flag for sleep disordered breathing that we should be looking at and referring them to providers. That is also something that some providers will say they will grow out of it. They do grow, they may not grind their teeth later in life, but it manifests as something else, like we talked about: increased risk of sleep disordered breathing, poor craniofacial growth, airway concerns.
Okay, Tamara, in the chat, we have 3 people say it's the left thumb and 2 say the right.
It's the right, so it's not flipped. I know it's kind of tricky if it's a picture,
but okay.
The right thumb, so you can see that imprint in the roof of the mouth. Thanks, Carla. So why does it matter that why does looking at the dental arch matter? It reduces oral volume, limits tongue space for proper tongue posture, like we talked about a little bit earlier. It contributes to poor nasal breathing, increasing the likelihood of mouth breathing. Think of the roof of the mouth is the floor of the nasal passages, the maxillary sinuses. And when the roof of the mouth is narrow, so are those nasal passages. So optimal nasal breathing is very difficult to achieve from a structural standpoint when that nasal passage is very narrow as well. And then, of course, because the narrowing of everything, it increases the risk of sleep disordered breathing. So the fourth observation would be tonsils. When we're doing our oral cancer examination, having the patient open, say, ah, we should be noting the size of the tonsils and sending them to an ear, nose, and throat physician if we see them larger than they should be, which I'm going to go over here so you guys can have a grading scale. I know we probably had gone through this in dental hygiene, but we're going to go over it another time here just in case, because everybody has different training. So this is called the Brodsky scale. This is what I use to glance at the tonsils to decide whether or not they need to be seen by a medical provider. It's a clinical grading system used to measure tonsil size relative to the oral pharyngeal space, often applied in airway and sleep assessments. This is another way that we can help bridge that gap between dental and medical. Because it describes how much of the airway is obstructed by the tonsils. So grade 0, this one here, that means that they are taken out. They'd had a tonsillectomy. Grade 1 means that the tonsils occupy 25% or less of the oropharyngeal width. Grade 2, it occupies 25 to 50% of the oropharyngeal width. Grade 3 is 50 to 75%. And then grade 4 is those kissing tonsils, which is 75 or more of the oropharyngeal space. So for me, I will always talk to parents about 3 and 4 and getting them seen by an ear, nose, and throat physician. It's very important. So here are some examples. So you can also put in the chat what grade do you think these tonsils are? And while you guys are looking and doing that, I'm going to continue talking about some of them. I wanted to note that even though we can see tonsils this way, in a CBCT, if our offices are doing that, you can tell the tonsils go much lower than what we can even see. So what we're seeing is just a little bit of them. So keep that in mind, because there sometimes will be smaller tonsils on the top, but as like if an ear, nose, and throat physician goes in there, a lot of the colleagues that I work with, they have said they take them out and they're even larger than they had anticipated. So that's why it's so important to have them evaluated by an ear, nose, and throat physician, because they can scope and decide what's best for that patient.
Okay, Tamara. So we have some multi. We have 2, 3, 4. Somebody has said all are grade 3. 3, 3, 4, 2, 3, 3, and 2, 3, 4.
We know none of them are 0, right?
Right.
None of them are 1. This, I would expect this kiddo CBCT to come back very interesting, much larger. But yeah, I would say grade 3, almost grade 4, grade 3, and then this one down lower, which I should have got a better picture. It was grade 4. They kiss at the very bottom there. So having them go and depress that little tongue, the back of the tongue down.
And Colette was the winner, chicken dinner.
So why does assessing tonsils matter in dentistry? So it increases the risk of tongue thrusting, contributing to open bites. So a recent meta-analysis by the American Journal of Orthodontics and Dentofacial Orthopedics found that children with tonsillar hypertrophy had a significantly higher prevalence of anterior open bite. Tongue thrusting and mouth breathing can also contribute to orthodontic relapse. And of course, it increases the risk of sleep disordered breathing because it decreases the oropharyngeal space. So the theory behind the tonsils being large and contributing to tongue thrust is that those tonsils are lymphatic tissue and they're inflamed. And so because they're inflamed, they're pushing the tongue forward, which is creating more of that tongue thrust swallowing pattern. So lastly, the 5th observation is patient symptoms. There are questionnaires that you can, validated screening tools that I talk about in one of the courses that I'm going to talk about here in a second, that you can either get or you can verbally just ask these patients while they're in the chair. I know I would be cleaning teeth, ask them a question, clean teeth, ask a question. So you can do that. while you are getting things ready or reviewing their medical history. So one of the questions you can ask is, do you snore or have noisy breathing at night? And so even though light snoring suggests partial airway collapse or obstruction during sleep, even though we snore and people think it's normal, it's actually a big red flag. Noisy breathing at night as well. So not necessarily that you're snoring, but you have audible breathing. We should be able to walk into a room and hear nobody breathing when someone's sleeping, which I know most of us are either going, my wife or my husband. I know my kid, all of you are thinking that right now because that's so common. Do you feel daytime sleepiness or morning fatigue? So feeling unrefreshed despite adequate hours of sleep indicates disrupted sleep architecture from breathing issues. So that would be a red flag. Mouth breathing day or night. Some patients are very aware if they're a mouth breather. Others, I will ask, are you a mouth breather? And their mouth will be open and they'll say no. So you got to get a little more creative with the questions. One of them would be, do you wake up with dry mouth in the middle of the night, like cotton mouth? Do you need to drink water because your mouth feels dry in the middle of the night or in the morning? Do you wake up with drool on your pillow? A lot of them will say yes, but they told me no, they're not mouth breathers. That would be signs. Another one would be clenching or grinding or jaw tension during sleep. Many patients with sleep disordered breathing subconsciously recruit jaw muscles to stabilize the airway, resulting in bruxism. So a lot of patients who are given night guards, think of how many people we've done that with, or our doctors have done that with. The underlying cause could be airway. Lastly, there's persistent nasal congestion, allergies, or feeling like they can't breathe through their nose. It can indicate airway restrictions such as a deviated septum and large turbinates, adenoids, of course, tonsils. Those are the people that we definitely want to refer to an ear, nose, and throat physician to get checked out. So let's review the 5 observations. I kind of like subdivided all of them and went a little bit more into detail. But basically you want to look at lip seal at rest, right, in the waiting room, tongue rest posture mobility, look at what the frenum looks like, look if there's a notch on the tip of the tongue. You can do all of this when you're doing your oral cancer screening. The dental arch form, look if there's a high vaulted palate, if there's any type of grinding that's occurring, incisal wear, occlusal wear. Tonsil size, assess if they have a grade 3 or 4 and need to be seen by an ear, nose, and throat physician, and then you can ask them those patient questions that we just reviewed. So we routinely evaluate structures directly involved in breathing as dental hygienists. That's why it's so important for us to evaluate this and get the patient to the provider they need to see. Again, we have frequent contact, which enables early detection of airway dysfunction. And our dental findings can often signal airway distress. Growth and airway outcomes are shaped in the dental years, not medical visits. So a lot of patients want to go see their pediatricians to ask about airway health. And I feel that dental hygienists and that are trained with this should be evaluating, because pediatricians have so many things they have to check off, right? And they're not deep diving into this airway world. They kind of know a little bit. So making sure that we do our due diligence. I'm very passionate about having these referrals to the right providers so these patients can breathe better, sleep better, guide craniofacial growth, and live a better life. I see way too often, including myself, like I said. So what are the next steps? How do I know when to refer to an ENT versus a myofunctional therapist or a sleep physician or an airway-focused orthodontist? The answer is, it's very tricky because these are all pillars that create airway health. Not one will fix everything. So ideally, if you see enlarged tonsils, you want to refer to ENT. Myofunctional therapists should be looking at all of this and connecting patients with the providers to be able to address all of these. For instance, I see a patient, I'm always going to look to refer to ear, nose, and throat physician. If they're having sleep disturbances or issues based on my screening tools, I'm going to have them go to a sleep physician. Sorry, did I say earlier ENT? And then I'm going to have them go to sleep physician. And then I'm going to refer to an airway-focused orthodontist, one that doesn't extract molars, one that has done extra training and really looks at the whole body and not just the teeth occlusion. It's very, very important, and most orthodontics don't get this training of airway in the dental field or in the orthodontic school, just like we as hygienists don't get a ton of this training in our hygiene school as well. So there's lots of resources to be able to find these people who have done the extra training and understand this. So I can help connect if you need anybody. So lastly, I have a little course here just to help kind of go more in depth. It's going to go over those quick screening tools in the office that I talked about. I go about in depth and about sleep and the different levels of sleep and why sleep is important and how airway contributes to that. Oral habits and their side effects, so thumb sucking, pacifier use from a myofunctional perspective. I give more examples of patients that I've seen, oral tongue range of motion that's restricted, more of those types of photos, and then supporting research and recommended books. So if you want to, it's $29. If you want to do the QR code, you can snap that there. I also have my contact information in the bottom, my email address, and then website as well. Thanks for having me.
That's a wonderful presentation. We have a few questions. One of the questions was, when kids have grade 4 tonsils, do they often present with being sick a lot in their health history or significant allergies?
Yes, I find that correlation often. A lot of
Okay.
you have recurrent strep throat. That's another one.
Interesting.
Nasal
Is it common to send people to their doctor first and then they say no problem, even though there will be flags?
100%. That's why I say refer to someone who's going to be doing the screening, right? So either a myofunctional
Yeah.
therapist, if they have that training, or an area focused orthodontist. A lot of them do those screening tools as well. So
Mhm.
it's very common.
Okay, great. One of the participants asked, will a copy of the slides be available?
If you want, I can offer it.
Alrighty. Um, Often with toddler parents, I get grinding brought up, sometimes daytime, mostly nighttime. Um, I typically send them to their doctor first, then ask them to get allergies checked, ENT referrals, etc. Sometimes they come back and say, everyone else said it's okay.
Yeah. Like I said, it's very
Any
common.
thoughts on that? Mhm.
It's common for that to happen. And so I always will recommend doing an airway focused provider of an orthodontics, right? So there are providers that will start expanding the palate at age 3 that can help
Mhm.
with breathing. You definitely still want the ENT and everybody else on board and have that patient evaluated, but connecting them with a provider that can help expand, you'll start to see some other issues dentally that with expansion can help breathing along with myofunctional therapy. Toddler,
Alrighty.
say, so over 4 years old would be myofunctional therapy. Under 4 years old would be feeding therapy.
Interesting. Um, One of the participants said she can't send directly to ENT as an RDH clinic.
Hmm.
They have to go through another provider. So is there
So
any suggestion?
is this in Canada? Because I know is it United States?
I'm not sure, they didn't say.
Canada,
I'm not sure. Um,
Canada.
I would
Oh,
so
Canada.
Canada, yeah. It's tricky. Canada's tricky because the healthcare system is a bit different. I know in the United States, obviously, some patients with an HMO insurance have to go through a provider. I would tell them
Mhm.
that to say to get a referral from their primary care to an ear, nose, and throat physician. Yeah, sometimes we can't
Okay.
do that either.
So how does your conversation go when you suspect the beloved pet to be an issue? Like maybe contributing to the airway issues of the child?
Oh, like they're allergic to the dog or the cat.
Mhm. Yeah.
It's so tricky because I'm an animal lover myself.
Mhm.
I usually will give sleep hygiene techniques. I will talk about air filters, less amount of dust, dairy, dander, all that stuff in the home. And then see how it goes. I mean, it depends on how severe. Even just nasal hygiene stuff would be helpful to reduce the amount of stuff they're inhaling. So I would definitely recommend an air purifier. See what they're allergic to, like allergy testing with an ear, nose, and throat
Sure.
physician. That way, we're not just assuming all of it, but trying to make the environment as much where there cannot be dander on stuff. So less hyperallergenic
Gotcha.
sheets, all of that stuff without having
All
to.
righty. The one participant had said in their area, they do not have an airway orthodontist. What's an alternative option?
That's tricky.
Mhm.
I have had patients drive and sometimes fly far to get
Mhm.
the care they need, just because when they have these issues that are just being fixed by occlusion and not looking at the whole picture, they're spending lots
Mhm.
of money just doing the same thing over and over and over and over. So if anything, just to get a consultation, there is a directory, many directories of providers that you may not be aware of. One of them is Airway Circle. You can go there and they have directories of providers there so you can find who's
Cool.
closest to you. But even just a town over, if it's, 30, 40 minutes, I would recommend it.
All righty. Um, would you do a scenario with a hygienist abroad to do initial assessment by the RDH and you do online therapy? So
Say again.
you as a provider.
Uh-huh.
Yeah, it's kind of trying to put it together as well. Would you do a scenario right now, I guess, with an RDH abroad to do initial assessment by the RDH and you do online therapy?
Oh, like
Like
help.
collaborate and lead them to the
Okay.
initial online. Gotcha.
So I've done a lot of networking, thankfully, to my colleagues and stuff about myofunctional therapy, gone to a ton of conventions, met a lot of people. Like I said, the directory for Airway Circle is huge. There's also the Breath Institute that has a directory. AHS is another one that has a directory. So looking on there,
Okay.
because those people who are on there usually have the same mentality of whole body health with airway.
Mhm.
So I will find a provider or remember someone that I met that was in that area and then connect with them and ask the questions about, who do you see, what ages, what type of modalities do you use, and connect them.
Mhm. Alrighty. Do you recommend removing tonsils along with adenoids for a child or just the adenoids?
That would be the ear, nose, and throat physician's call. I don't recommend
Okay.
taking anything out as far as removing anything because it's out of our scope. It's more of this is a red flag. I want you to go be seen by this provider that's in that specialty.
Okay. Alrighty. Any more questions coming in? I don't see any additional. Okay, here we go. For a narrow palate, what is the measurement to look for?
So you have to, for myofunctional therapy and tongue posture, we like to see so we're going to go from the mesiolingual, from the lingual gingival margin of the first molar, so number
Mhm.
3, to the lingual margin of number 14. And ideally, you want that to be around 40 to 45. Most of us are not there because we have small jaws.
Mhm.
That's the goal. Um, that being said, there's a lot that goes into that. As far as if it's too narrow, the tongue is not going to be able to go on the roof of the mouth. So for me, it's under
Mhm.
30, but then you have to look at the ratio. Like more petite people have smaller bones. You have to
Mhm.
actually, the orthodontic provider, map everything out and measure everything based on their skull size.
Mm.
But
Alrighty.
in my screening, I will note what they are, and then I'll have them go to orthodontist, the orthodontist to get the true reading through a CBCT.
Alrighty. How do you get how do people get referred to Mayo right now? Um, if it's not coming from the dentist? Like, where do you get your, your clients from?
Well, a lot of patients are either functional practitioners who are more
Mhm.
naturopathic providers. A lot of orthodontists are actually coming on board, at least where I'm at.
Good.
Chiropractors, but
Wonderful.
craniosacral people that are looking at, these things. So
Mhm.
multiple, and then friends of friends or
Yeah.
social media. A lot of social media people are on social media realizing they're not getting answers that they need.
Hmm.
So a lot of times I'll connect them with someone who's local to them.
Yeah. That's awesome. All righty. Um, I think that's the end of our questions.
Awesome. Those are good questions.
Yes.
Mhm.
Hmm. All righty.
Well, thank you everybody for coming. Colette, did you want to close that?
Yeah, I just thank you so much for showing us this. I love that it's like a 5 quick thing that we can kind of, you know what I mean? It's not like this big, long, drawn out assessment that we kind of couldn't dive into, but just like these sort of like red flags that we see, so we know when to move someone to the next step. But thanks everybody for coming and listening to Tamara. We are going to get this on our YouTube channel at some point. We just have to do a little bit of edits and whatnot. So if you know someone that ended up not being able to come, then just let them know to follow our channel, and it'll be great. So thanks so much, Tamara. Thanks everybody for coming. I'll end the recording here.